All right, so my charge today is to talk about my title, and so I don't have any disclosures. I wanted to just start with a take-home point. You guys didn't have a break after the presidential talk, and so if you need to use the bathroom, the answer is yes, it does work, so you guys can go to the bathroom. I know you guys, there's a lot of traumatologists here, you guys take general call. Just by a raise of hand, who fixes metacarpal and phalangeal fractures? Can I see? That's great, okay. And then who's ever put a nail in the phalanx or the metacarpal? I don't count you. So I have maybe like 7 or so. So if I get to 14, that's my goal, just to go to 100% success rate. All right, so this is a metacarpal, you put a nail, pretty simple, right? It kind of looks like a femur. So we all put nails in the femur. Femurs are probably a little bit harder, and so it's just like a femur, right? And this is a tibia. It kind of looks like a phalanx upside down. So the problem is, if you think of this fixation type as just a small little femur or a small little tibia, then you're going to miss that kids are not children, right? So there are actually some nuances to this technique, and we can make errors in this. And I'll discuss that, especially when I talk about rotation. So there is a learning curve to this system. It's not hard, but you should be mindful that it can be prone to some complications. So the better question, I think, is which fixation is better? And this is somewhat of a loaded question. I think this is still debatable. I've done all of this. I put K-wires, I put plates, screws, and then recently I've started putting nails. And I am what you would call like a laggard in the curve system. So in terms of using new technology, I tend to lag by like 5 to 10 years. I like to see results before I put in a new implant. So this new nail, the one on the right, I don't have any disclosures, but then it looks like a regular headless compression screw, but it's actually a non-compressive screw, and it comes in bigger diameters and has been advocated for use in this type of fractures recently. So which is better? Like I said, this is a loaded question. So you can make an argument to use either any type of fixation if you're looking at the considerations in terms of cost. We all know the K-wires are cheaper, right? And then, so if you just look at implants, you say, I'm gonna use the cheapest implant. It's gonna be a K-wire. But then what about surgical time? So let's say you're a plater, you like to plate, and it takes you 40 minutes to plate a metacarpal fracture. But what if I told you if you use a nail, you could half that to 20 minutes? How much is your per minute charge in your OR? For us, is around $200. So if I save 20 minutes, that's $4,000 in savings. Even though the implant might cost more, overall, it's actually cheaper. And then also healthcare costs. If I get union faster, then I have less visits into my clinic and then less x-rays, which will also lower the cost. So those are some of the considerations. So you also have to consider time to union, early mobilization. We all know that plates and a nail, you could mobilize them actually at time 0, usually. And when you use a K-wire, you could do limited mobilization, but you don't want to move them too much because you could get soft tissue irritation and increased pin site infections. There's also the topic of return to work in sports. I actually have a preference not to treat athletes, but then I did ask some of the gurus of, actually like Steve Shin, for example, in LA, who treats a lot of athletes out there, and I asked him, what do you use for athletes? He's been using nails for metacarpal fractures. In terms of biomechanics, at least for comparing plates and nails, in terms of 3-point bending, it's actually equivalent or even stronger with a nail than a plate, but then it's a little bit weaker in torsion. And in terms of soft tissue dissection, K-wires or a nail is more friendly than plating. And there's also associated complications that I'm going to try to discuss and give you some tips. So if you decide to ever put a nail, hopefully you don't make the mistakes that I have. So the original indications when we're putting headless compression screws were metacarpal transverse or short oblique fractures, which is defined as less than two times the shaft diameter is the length of the obliqueness of the fracture. And the reason why they didn't recommend that usually for like the comminuted fractures or the long oblique is that as you put the compression screws, then you would shorten. I think that's changed now with use of non-compressive screws, which like I said, the screw that came out, I'm not sure, like maybe 5 years ago, It's from Exosmed. It's got bought by Acumen. So they've been sort of increasing the indications. And so in terms of screws, there's the headless compression screws and then also non-compressive screws. So the first tip, if you're going to embark and start doing metacarpal nails, is that I think pre-op planning is actually key. I work at a trauma hospital, so I'm not like, we actually just walk in, it's like a Russian roulette, and then you fix it the same day. Maybe you have 30 minutes to pre-op plan. But metacarpal fractures, you have the luxury to see it as an outpatient, and you could pre-op plan. And so in this case, is pre-op planning on the PA view, and try to use the longest and widest nail. So you have to measure the isthmus, which is the narrowest part of the canal, and also the diameter to see how wide of a screw you could put, and also the length. So like I said, so biomechanically, you want to put the longest, widest nail. Fortunately for us, there are studies out there showing some of the typical dimensions of the metacarpals. This is a CT-based study. It's pretty busy, but then I think one of the just fun facts is that the ring isthmus has the smallest diameter. So in the ring isthmus, if you may probably put in like a 3.5 nail or a 3.6 nail, and the small finger actually has the widest diameter. So the small finger will take a 4.5 screw. In terms of length, the index metacarpal is the longest, and it gets shorter as you go towards the small finger. Okay. There's also studies out there recommending certain lengths and widths for screws based on some of the studies I've mentioned. This study, this is a good paper just to have in your back pocket. Every company will have some sort of headless compression screw, so you could, whichever flavor you want to use, you can. But remember, some screws, your longest screw might be like 3 centimeters, and you might actually need a 5 centimeter nail. And so just beware of the limitations of your fixation. So this is a case of a metacarpal fracture. The patient had a ring finger short oblique fracture. And then, as you can see clinically, had malrotation of the finger. I think one of the tips when you get started is that rotation is an issue. It's sexy to do it percutaneously, but it's not sexy when the finger is really rotated, right, post-op. So I think the easiest thing to do is when you're starting, until you get really, really comfortable with this technique, is to just make a small incision and clamp it, get it anatomic, and put a screw, such as in this case. And you can achieve early range of motion, pretty good range of motion, and also, I guess, perfect rotation. This is a patient, a 26-year-old rower, had a metacarpal fracture, had nationals in 2 months, right? So it's not so much they have to participate, they also have to train. And so how do you get them faster? And so you can get them faster to activity if you actually, we feel that if you put a nail. And here, she had it clamped. I think one of the tips here is that some screw designs have like self-cutting threads, and so you could put a wire, and if you don't ream, the potential complication that you could get is that you could have bending or breakage of the screw. So even though it has self-cutting threads, you should probably ream it. Okay, and so this is her results. Okay, pretty good range of motion. Another indication would be multiple metacarpal fractures. If you guys work at a trauma center, or if you see high energy injuries, if you see this like in a motorcycle accident, their hand is really, really swollen, is traumatized. You make 2-3 incisions, it gets even more traumatized. They get stiff, they get stuck. And so in this cases, if you could be as soft tissue friendly as possible, then actually you would probably improve their range of their ultimate outcome. This is a case for a revision. So this is a patient who presented subacutely with 2 metacarpal fractures. She presented 4 weeks out, so it kind of tells you something about the patient, right? He had 2 plates placed, 2 weeks, and then 6 weeks is broken because he was doing things he wasn't supposed to do. He also had a fifth CMC dislocation that we actually had missed. But then, as you can see here, there's a broken plate, and what do you do with that? So if you take out the plate and you put a new plate, the problem with the metacarpal is really small, right? So you have all these holes, so that's a concern. So instead of putting a plate, you could actually put a nail, and this is at 6 weeks. He has near full range of motion, okay? So this is, I think, one of the key things that a lot of times they don't talk about is to how to avoid malrotation and why it's important. I said that the metacarpal is not like a femur because would you guys care with a 5-degree rotation in the femur? Not really, right? You can't really tell. But in the hand, if you have a 5-degree malrotation in the metacarpal, that translates to 25 degrees malrotation in the fingertip. And so it's exponential. So you have to be careful. You have to get it perfect. And so one of the keys, like I mentioned, is to open and clamp it, and that's until you get comfortable. I like to use forearm blocks, so I'll put in a nail and then basically have to make a fist. If it looks great, then I'm done. If not, I could back it up, derotate it, and put it back in. There's something called Wallant, which was popularized by our Canadian colleagues because of OR access. Basically, you can use like Lido with tourniquet, Lido with epinephrine with no tourniquet, and you could do it wide awake. Another way to do this is when you're putting in the nail, you could actually flex the fingers in the palm, so you actually lock in the rotation while you advance the screw. So that's the metacarpal. For me, the big bang for the buck for me was the phalanges. And so the question is, which one is better? There's a plate, K-wires, and screws, right? And I'll tell you this. So I rarely plate the phalanges. For the past 9 years, I've been putting K-wires for the phalanges. And then recently, I've converted to IM nails, and I'll tell you why. So Dr. Stern showed us that for plating of the phalanges, this is an older study, but I think it still holds true. There's a lot of complication rates, 56% extensor lag, 28% major contracture, and the range of motion is terrible if you look at this. Even they use smaller, lower profile titanium plates in the study, but they still found poor range of motion. And so for a while, I was just K-wiring a lot of those fractures, and so it was better, but not perfect. I think for all of us who've treated these injuries, we have some slam dunks where they have full range of motion, but we have a lot of patients who actually lack normal range of motion. The total active motion here is 2,200 degrees, so 270 is normal. We have patients with PIP flexion losses and fixed flexion contractures. All of us will have this, right? And so how do we get better? And so for a while, like I said, I'm like a laggard, so I did not consider using a nail, except when I met Vicky. So this is one of my patients this is the patient that really made me start using nails. And so she's a 31-year-old woman. She had a fall, had a proximal phalanx fracture of her small finger, right? She had close reduced, and she still had a 26-degree apex volar angulation. Why does that matter? Because with a 26-degree apex volar angulation, you could expect approximately 25-degree extensor lags. And so I recommended surgical intervention. In my hands, acutely, it would have been this, K-wires, right? So fortunately or unfortunately for her, she actually, even though she came to the county hospital, she had no insurance, so she couldn't get treatment, and so like she couldn't pay for surgery, and so she elected to have it treated non-operatively. But 4 weeks, but then she got insurance, and so she ended up coming to my clinic with same angulation, and she's like, you know, I said, this is almost healed, and she said, I want you to fix it. And so I know if I re-break this and I put K-wires and immobilizer again for another 4 weeks or so, she's gonna have terrible motion, right? So this is when I started considering looking at the literature and really critically looking at the results. And then the results, I think, for the proximal phalanx with IM nailing shows that the range of motion is actually much, much better to the mean total active motion of about 250 degrees compared to 200 with K-wires. For the tips for the proximal phalanx, the preoperative plan is actually on the lateral view, not the AP view. You actually measure the isthmus on the lateral view. And there's different ways to fix it. You could go retrograde. One thing about going retrograde, I will probably never end up doing this because there's a central slip. It's been described, you could do it. I probably won't because if you damage the central slip, it's really hard to reconstruct it. You could go antegrade. This is useful for patients that are somewhat lax. You could actually sublux them. Or you could use an extra-articular cross. And I decided to do this for my patient because I was familiar with the extra-articular cross technique, at least with K-wires. Like I mentioned, there is a learning curve. These are some shots that I've taken. Usually, like proximal phalanx takes me about 10 minutes to fix. For this one, it took me 40 minutes. So 30 minutes extra. The implant cost maybe like $2,500, $3,000 per screw, right? You add that 30 minutes times $200. So it might be like an $8,000 difference between K-wires. And you're like, this is stupid. Why are you going to do that, right? So, but this is this is her motion at 10 weeks. Is this worth $8,000? I don't know. That's a question that you have to answer for yourself. For me, this is worth it. And this is her at 3 months. She had basically full range of motion, right? And remember, she came to me with a delayed presentation. Now, in terms of proximal phalanx rotation, this is what I found, is that for the left hand, for the right, it's actually going to be the reverse. But if you take your left hand and you imagine putting a screw clockwise, and you start rotating it, right? Once the screw engages the distal fragment, it will actually pronate it. And so the pinky actually will go, like the finger will actually go towards the ulnar side. On the right hand is actually converse. So this is the same patient. This is the right hand, the uninjured hand. Look at the pinky. It points towards the scaphoid tubercle, right? In her case, I did malrotate her a little bit. So look at the pinky is a little bit abducted out towards the ulnar side, and this is where it's pointing. Clinically, it didn't really make a difference, but this is what she complained about. So the take-home point, does it work? Yes. Okay, thank you.